And joining me now is the Assistant Secretary of Health. It's Admiral Brett Giroir. He is also a member of the White House Coronavirus Task Force. Admiral, welcome back to Meet the Press. And before I ask my first question, I do want to set things up with, since the start of this pandemic, I've had quite a few members of the Coronavirus Task Force on, and I've asked in various ways, where are we on testing and ramping up testing? And I want to play for you a sampling of answers dating back from April. Take a listen.
We're going to continue to fully partner with states around the country to increase the supply, to make sure that they have the reagents and the test kits necessary to perform those tests.
My job is to make sure people of America have enough of what they need going forward.
So we'll get this virus under control.
What we're doing now is we've got to test entire communities, find all positive cases, because this is a very different virus with this asymptomatic spreading. Get every positive case, get those people isolated.
Admiral, that last comment obviously was at the end of June. We're now at the beginning of August. We still seem to have the same testing issues. In this case, it's the supply issues and all of that, the lag issue, which you testified to on Friday. 4 months now, are we ever going to be able to get this testing strategy right?
So thank you, and it's good to be on again. And I do want to put some things in perspective. Of course, we've increased our testing by 32,000%. We're completing over 80% of our tests within 3 days, almost 90% within 5 days. Of course, we're going to improve that. We're continuing to improve that. By September, we'll have over 23 million point-of-care tests, so we are improving that. But I do want to get the opportunity to put testing in context, and I think that's very important, how we use it, how we rely on it, and how we fix the outbreak right now by using testing selectively the way we're doing it in all the southern states.
I'm curious with this selective testing, is this because we just don't have the capacity to do these quick? I mean, for instance, the Abbott tests, why is that not something the DPA could have been used for to make this available across the country faster, to speed up manufacturing? It seems as if we've let these private labs dictate the speed with which we get the equipment necessary to complete the tests.
So that's really absolutely not true. We look every day for opportunities to use the DPA or other investments, and when it's possible to do that, we do that. We've made 2 large investments into swab production. Last week, you saw an investment into BD Veritor by the Defense Department, an investment in Quidel by the National Institutes of Health. That's why in September, we'll have over 23 million point-of-care tests. The DPA is not a magic wand. It can't create something out of nothing. It can be used as an effective tool, and that's the way we're doing it. Now, let me talk about the testing, and this has been misconstrued a lot. Obviously, we want to increase testing, and we've done that, and I've told you how we've done that. But testing is a part of the strategy. We don't test our way out of this. We do smart policies with testing as an adjunct. That's why places like Arizona have had a 2-week downward trajectory. They've gone from over 5,000 cases a day to in the hundreds of cases a day. Florida, South Carolina, Louisiana, Texas are all on a downward trajectory because they've instituted smart policies. And you know what that is. Wear a mask, avoid crowded indoor places, use good hygiene, and avoid crowds. And if we do those things, that will reduce the overall outbreak to levels that will go down significantly, and that's what we're seeing across the South.
Let me ask this, though. It does seem as if we've got sort of 2 different challenges in front of us, right? Which is this latest outbreak. It seems like it's too big to get our testing around. There's some that are advocating partial shutdowns in some of these worst communities. Is that something the task force is recommending in these sort of red zone states?
So both for the red zone states and the emerging yellow states, we have really good data now, both theoretical and data from places like Arizona, Texas, and Florida, that if you do simple measures like avoid the indoor crowded places, and a lot of times that are indoor bars, but you can't have 100 people at your house either, do lessen dining, indoor dining, because that's another place. Wearing a mask is incredibly important, but we have to have like 85 or 90% of individuals wearing a mask and avoiding crowds. That is essentially gives you the same outcome as a complete shutdown. And why do I say that? Well, theoretically, we can go through the models, but look at Arizona, look at Florida, Texas, Louisiana. These measures are being implemented, and that changes it. And the key is, and that's why we're going to all the states, we're on local radio, we give specific instructions to every governor by county what they need to do when those counties start tipping yellow, because that's the time when you have to stamp it down. You've got to institute these measures, because the virus will keep doing what the virus does unless we make an affirmative change.
Sounds like you just made a case for a national mask mandate. If you're saying we basically need 85 to 90% compliance, sounds like a national mandate is needed. Is that a recommendation that's been made by the task force to the president?
So our public health recommendations is across the board, particularly in a red or yellow counties, that you really need to have mask wearing at a very high degree. There's a debate whether a mandate actually does an affirmative thing or whether people will rebel against that, but it really has to be voluntary by the American people, whether it's mandated by a city like it was done in Phoenix or certain states. But the public health message is we've got to have mask wearing. If you have mask wearing, you can reduce the R below 1 just with these simple measures, and we can stamp this outbreak out. If we don't do that, and if we don't limit the indoor crowded spaces, the virus will continue to run. And if you don't mind, let me just we are very concerned, and this is a very serious point, and deaths will continue to increase for the next few weeks because it's lagging. But we have decreased the amount of infections over the last 2 weeks. The hospitalizations have gone down. Unfortunately, mortality lags by a couple of weeks. So these measures do work, but they've got to be implemented rigorously.
One thing that seems to be scattershot is the issue of contact tracing. Now, it may take us back to our testing cul-de-sac conversation that we may go back to, and I know
yes.
I don't want to get caught in that loop again. But it does look like the contact tracing, is this outbreak too big now for contact tracing to be effective, especially since we don't have a national contact tracing army?
So, there's no black or white answer here, but in the very early parts of an outbreak or in the very late waning parts or in selective times like a meatpacking, contact tracing could be very effective. When you have a widespread multifocal outbreak where many people are asymptomatic, testing and tracing are of limited utility versus public health policy measures like mask wearing, like closing indoor crowded spaces. So yes, contact tracing is important, but it's much less important right now than the public policy mitigation measures. Once the virus gets down to very low levels again, then testing and contact tracing become much more important. Where we are right now with the widespread, multifocal across many states, just like many other countries, the solution was the mitigation steps, not the contact tracing.
Look, I know you're not a political person, but the president continues to advocate for hydroxychloroquine. Is that a danger to public health?
So from a public health standpoint, at first hydroxychloroquine looked very promising. There were not the definitive studies. At this point in time, there's been 5 randomized placebo-controlled trials that do not show any benefit to hydroxychloroquine. So at this point in time, we don't recommend that as a treatment. There's no evidence to show that it is. But on the other hand, we have remdesivir. We have steroids, which reduces mortality by 30%. We still don't know about immune plasma, but it has worked in many other circumstances. There are many trials, and you heard that national call for that. And a vaccine looks very promising as well. So we have many things that do work. Right now, hydroxychloroquine, I can't recommend that.
Now, I was just going to say, are you concerned, though, that because of this mixed messaging, that it's going to continue to sort of create this fog, if you will, about treatments and misuse of this drug?
So hydroxychloroquine needs to be prescribed by a physician. There may be circumstances, I don't know what they are, where a physician may prescribe it for an individual, but I think most physicians and prescribers are evidence-based and they're not influenced by whatever is on Twitter or anything else. And the evidence just doesn't show that hydroxychloroquine is effective right now. I think we need to move on from that and talk about what is effective. both from a public health standpoint. I told you the masks, the crowds, wash your hands,
right.
Avoid indoor spaces. And for treatments, we know that if you get COVID now, your chances of dying are incredibly less than they were in April because our healthcare providers know how to treat it better. We have effective therapies like remdesivir and steroids, promising therapies like immune plasma, and a vaccine really on the horizon.
Admiral Giroir, I have to end it there. I appreciate you coming on and sharing the perspective of the task force. As always, sir, stay safe and healthy yourself.
Appreciate that. Thank you.